Well, good morning, everybody. My name is Dana Barnes, and I'm the Business Development Director for Brookdale Senior Living in the North Houston area. And I'm so glad that you're here today. But I know also that if you're here today, you're looking for some support and solutions. And what I want to help you with today is to know when to consider dementia care for your loved one, especially if they are already living in an assisted living community. But this information will also help you know when to consider dementia care, even if your loved one is still living at home. This is a very important decision. The wrong decision can result in unhappiness, injury, or even death. But the right decision can result in independence and a sense of self-worth for a person living with dementia, and peace of mind for their family members and caregivers. Let's take a look at our objectives for today. Our first objective is to distinguish the hallmarks of dementia-specific care settings. Our next objective will be to identify the possible triggers that can make you consider a dementia care setting. Third, we will characterize the importance of transition planning for persons living with dementia. And finally, we will talk about strategies for reducing adjustment issues. But before we start in on those objectives, let's be sure we all understand what specialized dementia assisted living is. It can be a standalone community, or it can be a smaller section or unit of a larger community. It can be in a campus setting and part of a continuum of care. It is licensed as assisted living level of care, and it is typically secured. Why is it important, especially if your loved one already lives in an assisted living community? Well, this specialized care setting is important because recent reports indicate that there are a significant percentage of assisted living residents that have dementia. There are also a percentage of assisted living residents that have cognitive impairments that are not classifiable as dementia. Some of these residents have other active psychiatric disturbances, such as anxiety and depressive disorders. Behavioral and psychological symptoms occur in 90% of older adults with dementia at some point during the course of their illness. These symptoms include a range of neuropsychiatric disturbances, such as agitation, aggression, depression, and apathy. In tandem, estimates suggest that between 35 to 53% of assisted living residents take one or more antipsychotic, antidepressant, anxiolytic, that's a hard one, and sedative or hypnotic medications. Now that we understand what the research shows, let's begin with our first objective: distinguishing the hallmarks that differentiate dementia-specific assisted living from regular assisted living. The first hallmark we will talk about is specialization of associates and their dementia training and competence. The leaders of the community will have clinical dementia expertise and background, which includes gerontologists, nurses, and degreed therapists. Staffing is in higher ratios in dementia care settings and should meet the level of need based on acuity, both physically and behaviorally. Care associates are trained not only in Alzheimer's disease basics, but also in specialized techniques. These specialized techniques include prompting and cueing, validation and communication techniques, behavioral expression problem solving, and safety measures and crisis management. So we understand now that the first hallmark is the specialization of the associates and their dementia training and competence. A second hallmark of a dementia-specific care setting is person-centered care and consistent assignments. A person-centered culture meets a resident's needs for a sense of belonging, for a sense of purpose, for a meaningful daily activity, for maintaining their relationships with their family and others, and for preserving a sense of themselves. Consistent assignments mean that a care associate becomes a care partner who truly knows the person living with dementia. A consistent care partner can provide the best care clinically because they can note changes in condition much sooner, and they can detect even very slight changes in a person's condition, mood, or behavior. They also can foster a relationship, which is central to person-centered care, by offering a familiar touch or approach and interactions, which is very important to a person living with dementia. And consistent assignments are also good for families because they know just 1 or 2 caregivers per shift who know their loved one well. Another, increasing their self-determination and their choices offered to them, and providing them a day that is person-centered and related to their individual interests and history. All right, the next hallmark is a dining program that is choreographed with dementia in mind. The dining service is focused on their needs for support, and their care partners use prompting and cueing to meet those needs. So what is prompting and cueing? It could be just verbally giving an instruction, or it can also be demonstrating the activity that you want them to do. So we can do that during the meal setting. There's also a liberal amount of time that's allowed for the meals. They can take a little longer. Food is dementia friendly and safe. Now, what does that mean? Dementia friendly and safe. It could be, it's food that might be really easy to eat, that maybe it sticks onto a utensil easier than, say, like fresh peas. It can be cut up already or in small portions. We want to make sure swallowing is a function that can decrease as the illness increases. So we want to make sure that there's no choking hazards, or it could be food that's easy for me to pick up with my fingers even, so that I can still feed myself. And here's the important thing. Fine dining standards are still maintained in the same way you would maintain them for all assisted living residents. A very important hallmark is that the challenging behaviors of people living with dementia are viewed as expressions and communications and not problems. There is a culture of acceptance and understanding that behaviors are an expected part of the disease process. In a dementia-specific care setting, people with dementia are not defined by their behavior. Behaviors are viewed as a form of communication and expressions of unmet needs. Interdisciplinary teams focus on behavioral problem solving rather than behavior management. They focus on resolving behavioral expressions by using person-centered interventions and not the overuse of antipsychotic medications and other restraints. All members of the staff are involved in the solutions. Our understanding of good dementia care design has evolved at the same time as our understanding of both the disease and what constitutes good dementia care and programming. We have grown beyond the old medical model versus the social model silos, and we now understand that good dementia care design must support the disease and its clinical management, the program and its social requirements, environmental codes and life safety, and most of all, the needs of the person. A specialized supportive environment prevents residents from wandering out of the community and potentially experiencing harm. It allows for a sheltered freedom, maximizing independence while remaining secure. It makes sure that residents have a safe place to wander freely without being told no. It provides consistent staff observation of a resident's whereabouts, and it uses techniques that make sure the residents feel a sense of belonging and purpose and feel reassured as to where to go next. And it ensures that their physical and safety and emotional security. It also promotes a positive social atmosphere and encourages family visits. Person-centered care must be supported by an environment that provides a variety of spaces for activities and tasks. It maintains a place of sensory stimulation and sensory calming. Okay, our last hallmark comes in conjunction with the Alzheimer's Association, which created guidelines about wandering for assisted living and skilled nursing communities to better serve the daily challenge of elopement risk. Elopement risk would be exit seeking, somebody who wants to leave the building. So these guidelines recommend that there is an evaluation for exit seeking behavior prior to the resident moving in, that service plans that promote resident choice, mobility, and safety as mechanisms to manage elopement or exit seeking behavior, and an environment that incorporates features of home and not institutional life. Nobody wants to live in an institution. We have looked at some of the most important hallmarks of a dementia-specific care setting. We talked about the specialization of the associates, person-centered care and consistent assignments, structured day of care, specialized dining programs, behaviors viewed as expressions, and supportive environment and safety. We can also talk here, just real quick, about the benefits of to the patient's doctor in recommending their patient for dementia-assisted living. So first, there's a reduction of risk and increased safety for the patient. Second, there is an increased opportunity for the patient to experience successful living with dementia versus probable disengagement in non-specific settings. Third, there are many opportunities for family education and support. And finally, there are expert nursing care partners skilled in dementia care who can offer a greater understanding of behavioral symptoms, which leads to less psychotropic usage and therefore fewer calls to the doctor, and are better able to read a resident's physical condition and catch co-concurrent illnesses very early. Okay. Now that we understand some of the hallmarks of the dementia-specific care environment, let's look at some of the triggers that might lead someone to consider a person for special care for this special care environment. Of course, the first thing that comes to mind when we think of triggers or alerts is whether the person living with dementia is safe and secure. Here are some things to consider. Are they an elopement risk? Do they often try to leave their current living environment? Do they have a diagnosis of dementia, which with a safety issue that would benefit from a specialized environment or approach? What is their level of orientation to their current surroundings? Is there a possibility that they may leave home and be unable to find their way back? Do they frequently state that they are going someplace unrealistic, like, headed to the bank at 3 o'clock in the morning or to work when they're retired from work? So here's the deal. Follow your gut instinct here. Would you feel comfortable with them being outside their current living environment alone and unsupervised? You should also consider their level of judgment when considering whether they are safe and secure. Judgment is lost early in the disease process, and frequently persons in the early stage are at a higher risk for elopement. They may be all dressed up with nowhere to go. They often can figure out codes and alarm systems, and they can still conceive an elopement plan, although they may have a lack of follow-through. Are environmental modifications needed for their safety? Do they need secured and alarmed exit doors? Do they need secured outside courtyards? Do their windows need to be locked or alarmed? Research done by Alzheimer's Australia found that residents who reside in environments designed specifically to meet their needs have a much higher chance of retaining their abilities and also experience a higher quality of life. With this in mind, let's look at triggers and concerns related to their activities of daily living and care needs. Is their daily function level largely dependent on others due to cognitive decline? Do they require verbal gesture or physical prompting to complete tasks? Do they need more cueing with food intake because they have issues with weight loss, are decreasing their consumption, or have increased dehydration? Are they falling more often, or do they need complex condition management? There are behavioral and psychiatric triggers to consider as well. Is there an increase in behavioral symptoms such as agitation, resistance during care, wandering, demonstrating continual need for structure and direction? Does their behavior require continual problem-solving efforts from the staff or their caregiver? Are psychiatric symptoms present, such as delusions, hallucinations, or paranoia? Does their behavior require psychotropic medication management? Do they display a lack of impulse control and increased executive function issues, such as sexually acting out or having verbal outbursts and taking things from other rooms? Does their behavior place them at risk for isolation from other residents and relationships? And last, what psychosocial triggers should you look for? Well, are they unable to manage themselves during unstructured time? So for example, do they wander in a confused manner and appear to require a consistent structural flow to the day? Are they unable to initiate activity independently? Do other residents or caregivers in their current setting demonstrate less and less tolerance for their behavior or memory loss? Do they have a co-concurrent depression diagnosis? And is the family in need of more dementia-specific support? We've discussed a number of triggers in areas of safety and security needs, activities of daily living and care needs, behavioral and psychiatric needs, and psychosocial needs. Okay, so I know this is a lot of stuff we've already talked about in such a short period of time. So I don't want you to worry about trying to write down a ton of notes super fast, because I do have a handout that has that's a summary of everything that we're sharing today. So Catherine will be sure to get that out to you. Okay. Objective 3 targets the fact that it is very important to consider the ability of the person with dementia to transition successfully into specialized care environment. You need to develop a transition in plan prior to the transfer or move in to help facilitate the process. And people living with dementia should be prepared. No one should ever just be dropped off. A well thought out plan can maximize the adjustment to the new environment in order to minimize behavioral expressions and allocation trauma. A transition plan is especially important if the person with dementia has a lowered stress threshold and limited tolerance of stimulation, is very attached to the presence of a particular caregiver or family member, does not leave his or her residence to attend church, dine out, or visit family and friends, has comorbidities that compromise abilities, or is used to being in charge and in control of their own selves. When is it time to execute the transition plan? Well, objective 4 is to have strategies for reducing the adjustment issues. Caregivers and others in the new community need to be aware of critical information regarding the person with dementia. It is very important for them to discover, consider, and integrate into the care plan a person's normal routine around and comfort level with dining, bathing, sleep and wake times, toileting, appearance, modesty and their need for privacy, their comfort with touch and affection, and their common terms and language. If you or your loved one has received a diagnosis of dementia, you will be dealing with the question of specialized care at some point, and probably sooner than later. It is important to be prepared to help with this decision, and the more you understand when to consider specialized care, the better prepared you will be. It seems that we tend to finally consider dementia care after we've exhausted all other options. But today we learned the great benefits to the one with dementia and to their families of finding that care for them even sooner. So I encourage you to take some time, visit some places offering specialized dementia care so that you can know what your options are and take advantage of them earlier and not be faced with making the decision in a hurry. All right, I think I'm a little short, but thank you very much for joining me today. I understand.